the third part to the lecture on the regulation of cardiac output and venous return. We're going to be looking at factors that can alter cardiac output and venous return, and we're going to start by looking at conditions that are associated with abnormally high levels of cardiac output or low cardiac output, and ultimately a lot of them are linked to abnormalities in venous return. So the first four things we're going to look at are conditions that are associated with high cardiac outputs. And for the most part, you're going to see that they're associated with reduced levels of total peripheral resistance, which would increase the amount of venous return and lead to high cardiac outputs. Now, beriberi, we have mentioned in the past, this is a result of a thiamine deficiency or vitamin B1. With a vitamin B1 deficiency, you're unable to make adequate levels of particular coenzymes or cofactors, in particular those that are needed for energy generation. So with an inability to properly utilize the nutrients that you have to convert them into energy, tissues are going to think that they need more blood, even though they cannot effectively use those nutrients. The blood vessels will dilate, increasing flow, and all that increased flow leads to increased venous return and high cardiac outputs. The other one I want to mention is hyperthyroidism. With hyperthyroidism, that's associated with increased metabolism. With increased metabolism, you're going to be producing a lot more metabolic byproducts. You're going to be in need of more oxygen. And if you remember the lecture on the local control of blood flow, you're going to associate that with, okay, I have the metabolic byproduct theory or the vasodilator theory in place and the oxygen demand theory in place. So both of those could result in vasodilation to increase blood flow. Again, increased blood flow results in increased venous return and increased cardiac outputs. Anemia. With anemia, if you don't have sufficient blood cells or sufficient ability to carry oxygen in those red blood cells, blood vessels will dilate because they don't have enough oxygen to produce ATP. That would increase blood flow again. Also, if you have anemia as a result of a reduction in red blood cells, blood viscosity would be decreased, which would also increase flow. Now, an AV fistula, or an arteriovenous fistula, this is an abnormal condition in which you have shunting of blood from an artery to a vein. It can affect any tissue or organ, but it often affects the peripheral circulation. But if you have an abnormal connection between an artery and a vein, a lot of blood is going to go from the artery into the venous system, which will lead to abnormally high levels of venous return and thereby cardiac output. Conditions associated with low cardiac outputs would be things that would make the heart work less efficiently. So if the heart's not as an efficient pump, maybe lack of oxygen to the heart, if you've got some valvular defects, some cardiac or congenital defects in the heart would be a less effective pump. Anything that decreases venous return would decrease cardiac output. So we have to think about what type of things would decrease venous return, which is some of the things that we're going to be mentioning after a couple slides. Another thing I want to mention is something called cardiogenic shock. Cardiogenic shock is a specific example of shock. Shock, when you think about shock, you automatically think really low blood pressures, which have various effects, obviously. But there's a lot of causes of shock. In this condition, we're talking about cardiogenic shock. Some heart dysfunction. So ultimately, the heart is not functioning effectively enough, in which it results into a state in which your tissues are not perfused adequately. And this leads to massive drops in blood pressure, because if tissues are not being perfused adequately, vessels will dilate to try to increase flow. But unfortunately, the heart's not working like it should. And so all of this dilation leads to massive drops in blood pressure. The low cardiac output also leads to drops in blood pressure because something is happening that the heart is not working as an effective pump. Now, there's a number of different causes of cardiogenic shock. Most often, lots of times, it's from an acute MI. So I'm going to take this chance to kind of bring back some stuff that we've already talked about in the beginning part of the trimester. So if we have a patient that comes in that they do an EKG on them, and the EKG indicates that they're having a heart attack. They've got significant current of injury going on in a particular part of the heart. So they're observing an ST segment shift in a certain part of the area in the heart. They're having chest pain. So they're very weak. A lot of different things are going on, and they do an angiogram, and they notice there is significant reduction in blood flow in the left anterior descending coronary artery. And that would impair blood flow to a significant part of your heart. That's a major vessel in the heart. Well, the patient was noticed to be what we call in cardiogenic shock as a result of this acute MI. They did an emergency angioplasty. Here's pre-angioplasty, here's post, and even though you're like, well, I don't know if this is normal or not, it's fine. I probably would have a hard time with it too, but I can at least compare pictures and say there's a difference. I can tell here there's much better blood flow over here. So they did an angioplasty, inserted a stent, which improved blood flow to the heart. You notice, look at this. I mean, here, there's a significant part of the heart that was not getting sufficient blood flow, which was leading to the heart not being able to work as an effective pump. Now, you can have cardiogenic shock without an infarction. It could have been an injury. If you weaken the heart enough that it could lead to cardiogenic shock. It didn't have to lead to muscle death. Obviously, if you weaken the heart enough and you had cardiogenic shock and caused some other tissues peripherally, it still could lead to death. So, but with the restoring of blood flow, they were able to improve function in this patient, and the patient was able to recover. Now, what I want to do is look at some factors that can help determine venous return. So, I'm going to introduce some new topics to you and review some old topics that we've already talked about. So, first thing I want to look at is the role of pressure gradients in venous return. So, pressure gradients determine everything. I know to get blood from point A to point B, you better have a pressure gradient. Well, when we talk about venous return, two pressures that are going to be important. First one is right atrial pressure, something we've already talked about, or central venous pressure. That's the pressure right here, the junction where the veins, the great veins, meet the heart. That should be about 0 millimeters of mercury. That is a backwards force. That exerts a backwards force on the veins to impede flow to the right atrium. So you want to keep that as low as possible. So I want to keep it 0 millimeters of mercury. Over here, this pressure here, 7 millimeters of mercury, this is the number I want you to remember for this. Mean systemic filling pressure. So this is the pressure in the periphery here. It's a major pressure that's pushing blood back to the heart. So I want this a pretty good number. I want a gradient to ensure I get blood back to the heart. So I got to talk to you about the history behind what the mean systemic filling pressure is. Well, we have to start talking about something called a mean circulatory filling pressure. So you think circulation. Mean systemic filling pressure is part of the mean circulatory filling pressure. The mean circulatory filling pressure includes the systemic circulation and the pulmonary circulation. So if I say mean systemic filling pressure, I'm talking about the systemic circulation, and I've taken away the pulmonary circulation. Okay, so how do they end up coming with these numbers? Well, the mean circulatory filling pressure, as well as the mean systemic filling pressure, is actually a fictitious pressure. They made it up, in a way. So I'll tell you what they did. Arthur Guyton, again, is the author of your textbook, measured the filling pressure in animals by suddenly stopping the heart, rapidly pumping blood from the aorta to the vena cava until all the pressures equalized. So you can figure out what the number is. They had to do this very quickly before any autonomic reflexes kicked in. They measured it to be about 7 millimeters of mercury. Now, this was done in dogs, okay? It's never been done in humans, because how many humans are going to be willing for them to go and stop their heart, rapidly move blood around their circulation so it's equalized? No, because your chances of something bad happening way high. So this has never been done on humans. It has been done on animals, so they approximate it's the same in man. That's why I call it a fictitious pressure. When they did the mean circulatory filling pressure and you take away the pulmonary pressures in the pulmonary circulation, it's still about 7 millimeters of mercury because the pressures in the pulmonary circulation are so low. So that's why they came up with the number 7 millimeters of mercury. So what type of things can influence these two pressures and therefore determine venous return? So that's what we're going to be talking about shortly. But while I'm here, I might as well talk about these other things here. You see that it's written on your page. So you'll notice they have this thing called central venous pool and a peripheral venous pool. So let's talk about the peripheral venous pool. This is a large blood reservoir that's containing most of your venous blood. And it's about 64% of your blood volume at rest is found here. So we have a pool of blood in the periphery. And some of this is going back to the heart at a certain rate. And this is our venous return. Venous return is a volume going back to the heart per unit time. It should be equal under resting conditions about 5 liters per minute. Here in the central venous pool is a smaller reservoir of blood considered to be kind of like in the thorax region. The great veins of the thorax, the right atrium, is considered your central venous pool. Well, blood leaves the central venous pool at a particular rate. And what would be that particular rate? Blood leaves here at a rate equal to your venous return, which happens to be your cardiac output. So blood leaves the central venous pool at a particular rate, and it's going to be at whatever your cardiac output is, and since venous return is equal to your cardiac output, they should be the same. So under resting conditions, it's going to be about 5 liters per minute. But what could determine the cardiac output and the venous return? Maybe things like changes in venous resistance, which may impair or affect this pressure. What about factors that influence this pressure? Maybe something's going on with the heart that can affect this. So let's look at some things that can determine that venous return. Well, if I change that driving pressure back to the heart, that mean systemic filling pressure, that could affect venous return. So how can that happen? Let's look at changes in blood volume. So first scenario, I have an increase in blood volume. How would that affect mean systemic filling pressure? An increased volume of blood in the venous system could increase mean systemic filling pressure because you have a certain amount of blood, a fixed amount of space. That can increase mean systemic filling pressure, which would increase venous return. You can use the other scenario, though. What if I have a drop in blood volume? A drop in blood volume would decrease this pressure, which would decrease venous return. So say if you're hemorrhaging. What about the role of the sympathetics? Veins, the larger veins are innervated by the sympathetics. So if I activate or stimulate the sympathetics, that will increase the mean systemic filling pressure. It increases by decreasing the area, got a certain amount of blood in a smaller space, pressures increase, that would help to increase venous return. Great example would be during exercise. How do you think you're going to borrow the blood to help increase cardiac output? You stimulate the sympathetics, you borrow the blood from the venous system, increase mean systemic filling pressure, which increases venous return. which increases your cardiac output. What do you think may happen, or what do you think we have in place to protect ourselves to try to maintain adequate cardiac outputs if you're losing blood? So if I'm hemorrhaging, one of the reflexes that kick in would be a sympathetic reflex to stimulate stimulate sympathetics to increase that mean systemic filling pressure and get blood back to the heart. What about if I inhibit the sympathetics? If you inhibit sympathetics, this pressure decreases, that's a new word, declines or decreases, which decreases venous return. Let's think about a scenario that we've talked about that this could be play a role in. Vasovagal syncope. Remember, with vasovagal syncope, you have major inhibition of the sympathetics. You pass out. Why do you pass out? Not enough blood, not enough cardiac output, not enough blood pressure. So if I decrease mean systemic filling pressure, I have less blood going back to my heart, and thereby less blood going to my brain too. You're going to pass out. So big thing to remember, when you look at these two numbers, this normal gradient for venous return is about 7 millimeters of mercury. The bigger the difference between these two numbers, greater this is, then you're going to have greater flow. As this gradient declines, flow decreases. If there is no gradient, no flow. So if this number is equal to that number, or this number is equal to that number, either way, you can look at it either way, you will have no flow. If these both are 7 or they're both 0, not going to have any flow. So let's give you a couple scenarios, and one we've already talked about. So if I'm hemorrhaging, so with hemorrhaging I can lose enough blood that this pressure, this mean systemic filling pressure, decreases. That pressure decreases, there's less of a gradient to get blood back to the heart. Venous return may drop, and therefore cardiac output can drop. If you have heart failure can cause a change in this pressure, that central venous pressure or the right atrial pressure. In heart failure, these pressures may start to increase, which would oppose more blood coming back to the heart, lead to a less of a gradient. That would decrease venous return. So big picture stuff. Know which of the two pressures is driving blood back to the heart, which is opposing blood going back to the heart. What would happen to each pressure, or if I change the pressure, what happens to the gradient? What happens to venous return and therefore cardiac output? Let's look at the role of venous resistance on affecting this venous return. So if you look at this picture that's in your manual, we're going to start here. Normal right atrial pressure is 0. Normal venous return is about 5. You just look at this blue line in the middle. According to this blue line, if right atrial pressure increases, venous return drops, okay? Because that's an opposing pressure. If I decrease right atrial pressure, venous return goes up somewhat. Here it's getting a little subatmospheric to a point. Doesn't go up a lot, to a point. When you get up too much, what happens is the veins collapse because veins aren't very thick. So when pressures get to subatmospheric, they will actually collapse. Now then look at what we do when we apply changes in resistance. So according to this, if you look at, if I'm starting right here, normal right atrial pressure, normal venous return, if I decrease resistance, we're talking resistance in the venous system, return goes up. If I increase resistance, return goes down. But think about it. You already know the flow equation. If I increase resistance, that means less flow. If I decrease resistance, that means more flow. So what type of, usually not an issue. So what type of things could affect resistance? If you're pregnant, tumors can compress large veins. You know, babies compress large veins. That could increase resistance. We've talked about that in the past. Now, generally, lots of times, if they start doing that, mean systemic filling pressure is going to start to increase to try to force more blood back to the heart. But if not, resistance enough, everything's going to back up, and it can lead to swelling in the feet, varicose veins, all that good stuff that we've talked about in the past. But big thing though, I do want you to remember that if you have resistance, that always, if I have an increased resistance, that always is going to pose flow, because flow is equal to delta P over R. So an increased resistance would be associated with a decrease in flow and vice versa. Now this picture is very similar to what you saw before, without all, it was like that normal curve, but I've taken out those curves for resistance on there. So this again, what this is showing is the venous return curve is very similar to the cardiac function curve. Here we're looking at the relationship between right atrial pressure and venous return. That cardiac function curve was looking at the relationship between right atrial pressure and cardiac output. So here, you'll notice again, normal right atrial pressure of 0, your venous return is about 5 liters per minute. You'll notice again, as right atrial pressure increases, venous return drops because you have a less gradient. As right atrial pressure drops to a certain extent, venous return increases, not very much, but it does, but at a certain point, you can't increase it anymore because you start collapsing those veins. You'll notice when right atrial pressure is equal to your mean systemic filling pressure, you have no venous return, so it's about 7 millimeters of mercury. That's the big thing I want you to get from here. So here's a potential question that you may get, or questions you may get on an exam. Okay, one thing I definitely want you to remember is that, okay, what is normal venous return under resting conditions? And you're like, oh, 5 liters per minute. Note it. And what's cardiac output? 5 liters per minute. All right. What would be an associated venous return with a right atrial pressure of 4 millimeters of mercury? And I'll give you some choices. You pretty much are going to be looking for venous returns that are less than normal, because you already know that if I increase right atrial pressure, venous return should decrease. And normal venous return is 5 liters per minute. So you're going to be looking for something that's less than 5 liters per minute. If I said, what would venous return be with a right atrial pressure of 7 millimeters of mercury, you're automatically going to say 0 liters per minute, because you know 7 millimeters of mercury is the mean systemic filling pressure. So there'd be no gradient, no flow. And so venous return would be 5 liters per minute. What would be an associated cardiac output with a right atrial pressure of 7 millimeters of mercury? You're going to say 0, because venous return should be equal to cardiac output. If I don't have venous return, I don't have cardiac output. So it's going to be 0. Now the last picture that you have in your notes, just ignore. I hate that picture. I should have taken that a long time ago. Big thing I want you to remember, don't even look at the picture, just listen to me, is, and I'm going to go back because I don't like that picture. Big thing always remember is cardiac output should be equal to venous return. So when we look at what we've done so far throughout these webinars, is what determines the cardiac output? It's venous return. And what determines venous return? Peripheral factors, things that affect the peripheral circulation, which ultimately would affect the pressures that are driving blood back to the heart. At some point, the heart can be a limiting factor. If the heart fails, it will not be able to pump out whatever you give it. But under normal physiologic conditions, whatever you give the heart will pump it out. So whatever determines the amount of blood coming back to the heart will ultimately determine your cardiac output.